Well, good morning, good afternoon, or good evening, depending on where you're tuning from. My name is Dr. Sam Talpis, and it is my absolute pleasure and honor to be here today to talk to you about a topic that I'm very passionate about, zirconia implants. And I'd like to thank Z Systems for this opportunity. So, my aim for you today is to at least be inspired to consider zirconia as a viable treatment option or modality within your practice. So I'm a brand ambassador for Z Systems, and I have no financial or ownership in any of the implant companies discussed, even though I'd like to very much. So just a little bit about me. I am from Melbourne, if you're from America, Melbourne, Australia. And just to give you a little bit of context about Australia, our quality of dentistry is very high, yet we're quite conservative. And what that means is we're not really pushing the envelope. Not a lot of people are doing a lot of immediate, a lot of full arch immediate loading, or specifically ceramic implants. There's a handful of people in the whole of Australia doing this on a regular basis. So it's something that I've really had to build from the ground up. I didn't really have a lot of mentors. It's something that I did a lot of trial and error and spoke to a lot of clinicians from around the world. So I worked in an all-on-4 clinic early on in my career, which gave me a lot of experience with full arch cases, with a lot of loading, with a lot of extractions, full mouth rehabilitations, and I got to see a lot of successes, but also a lot of failures, a lot of biomechanical failures, full arch cases fracturing, distal cantilevers. I saw a lot of peri-implantitis, a lot of implant loss. And so that really set me up for going into a holistic practice, which is really on the other end of the spectrum. And a lot of the patients demanded ceramic implants. And this is something I'd never heard about. I was used to working with titanium. They work generally quite well. The research, the studies showed that they're very successful over a long period of time. And yet these patients were asking me of something that I had never heard about. And my natural gut feel, my natural instinct was to say that they all fracture. That's the way it is, right? You drop a plate on the floor and it's going to shatter. And yet so many patients had asked me for it continually to the point where they said they wouldn't have any implants. They were walking around with dentures, with missing spaces. And so I decided, okay, I'm going to look at the data. I'm going to go and visit these places. So I had the opportunity to visit many companies in Switzerland, Germany, the US, Spain, and I got to see the manufacturing process. I really got to understand the material. I spoke to a lot of clinicians who'd be placing these over a long period of time with a lot of success, and I was very convinced. And so now my practice is virtually based on ceramic implants with, again, some cases, including full arch cases, all on four, where we're still doing titanium. And I also co-established Australia's first ceramic implant clinic. So today we're going to be talking about why zirconia implant. What's so special about them? Why should you know them? Why are patients talking about them? What makes them really unique? We're going to talk about what zirconia actually is. I know when I first started, I couldn't quite get my head around, is it a metal? Is it a ceramic? Is it a hybrid? And there's a lot of myths, even within the profession of what it actually is as a material. We're going to talk about the biology and evidence. Does it osseointegrate as well as titanium? What about the times? What about soft tissue integration? And most importantly, what's the data showing? We're going to talk about case selection, specifically green cases, yellow cases, and red cases, which ones we should tackle early on in our career, as opposed to somebody who's quite experienced. We're going to talk about the surgical and prosthetic workflow. What are the steps involved? How do you go from implant placement to putting a final tooth on? And finally, the actual application. How do we do it? Which cases and what are some of the limitations of zirconia implants? So, a really fundamental question is why are we talking about zirconia? Well, it's 2026, and whether you like it or not, patients are really aware. They're looking at social media, they're looking at wellness communities, peer networks. People are talking about them. It's no longer the dark ages, with all the information available, it's something that is here to stay. 10 to 15% of all implants placed in Europe and America are zirconia, and these numbers are growing. And expectations are really high. Veneers are everywhere. There's so much. about aesthetics, about looks, about white, and it's really time we start to consider this as a viable option. So, some of the clinical drivers: increasing patient requests for metal-free solutions. Whether you're working in a holistic practice or not, patients are going to come asking for this, demanding for it. High aesthetic expectations in the anterior zone. Again, social media shows, and we all know it, our own cases. You see these cases and you feel like an inferior dentist. How do these clinicians get such great results? Thin biotypes, they're really challenging, even with soft tissue grafting. You can develop scar lines. There's a lot of issues with recession, exposing the implant abutment junction. I wouldn't necessarily say that there's been a huge evolution in ceramic implant systems, but the implant systems that are here now, the ones that have been here for a long time, they are continually developing, getting better, stronger results as well. So the clinical question is not zirconia implants better, but rather where are they appropriate? Having worked in a holistic practice for over 12 years, I can confidently say that a lot of patients are really concerned about what's in their mouth. They've watched documentaries such as Root Cause. They've seen Instagram posts, these bio or holistic dentists that are advocating removing all root canals, removing all metal, not using titanium implants. And this is really, fear-mongering. And these patients are not only concerned, but they're actually very scared that they're going to end up with cancer, all these debilitating conditions. And so this is something I'm very passionate about in the sense that, I think as a profession, we owe it to our patients to give them good data. A lot of these common myths or a lot of these dentists who are promoting these have absolutely no scientific evidence. And so, I think intuitively, that a small number of patients may not be able to tolerate certain materials, but it's far in between all the patients. So, where are they appropriate? What certain cases? Let's go through it. So, what is zirconia? Well, zirconia is not a metal. Zirconia originates from zircon sand or zircon or zirconium silicate, which is a naturally occurring mineral found along the coastlines. Australia is one of the places. So, zirconia, being a metal, is one of the biggest myths around, and even dentists don't know this. And am in continual disagreements and discussions with my colleagues, with ceramists about what zirconia actually is. So, when zircon sand is heated up to around 2800 degrees, Celsius, it turns into zirconia, and with a specific chemical reaction, it turns into zirconium, which is not firstly stable at room temperature, and it doesn't actually exist naturally in nature. And when it is created, it's used for nuclear reactors. So again, zirconium dioxide, is a ceramic oxide. It's not a metal. Zirconia needs yttria in order to turn it into a stable form. Otherwise, in this initial form, which is monoclinic, it's not very stable and it has a high propensity to propagate cracks, and that's why we don't really tend to use that form. And as you can see on the right, that is a ceramic rod, a hip TZP ceramic rod, in which these ceramic implants are milled from, and they're very strong. So let's talk about this diagram, which looks at the transmission, also known as translucence, versus the flexural strength. We all want this elixir. We all want something that's really translucent and yet incredibly strong. And unfortunately, that's a balance that we have to compromise on. So as you see on the left, we have a lot more translucency, things that we use in the anterior region, central incisors. We can use veneers, but the downside is that the flexural strength significantly drops. Now, as we see on the bottom right, ATZ, which is also known as alumina toughened zirconia, we generally use that for the cutting instruments, the surgical drills, which are metal free, and it's very tough, very sharp, very hard, but it has some huge downsides, and that's why we don't use it generally as a ceramic material. We generally tend to use TZP, which is tetragonal zirconia polycrystals, and very strong implants such as Z systems, HIP process, which means hot isostatic pressing, essentially meaning that it's fused under enormous stress, under enormous pressure and temperature in order to generate something that's very, very strong, something that has or all the microscopic impurities have been removed. I wanted to show you something a little bit different. This is a material that is called Ice Plus from the brand Zirconzan in Italy. And the reason I want to show you this is that modern ceramics have reached unbelievable mechanical properties that rival and in some cases exceed metal alloys. Now, if you look at the case on the right, which is your traditional FP1, this was only able to be done in metal with porcelain fused to the metal. And we often would experience issues, big biomechanical chipping, veneering chipping, fractures. This was a huge problem. And yet now we have this material, which is generally hot bonded. We've got zirconia, hot bonded to zirconia. It can be porcelain can be added without necessarily de-cementing it. 1900 MPa is unbelievable. It's incredibly strong. So we're doing a lot of this in Australia and for FP3, FP1. So the generation of modern ceramics just keeps getting better and better and better. So let's talk about the brief history. Well, this is where that common belief that ceramic implants fracture really comes from. It's talking about alumina, aluminium oxide, which is really quite weak. It doesn't have any uterus stabilization. And if you look at the studies, the survival rate is very low, it's varied. And in actual fact, if we look at the time factors and the history of this was the world's first immediate implant in 1974 called the Tübingen implant from Germany. We actually look at the brief history of ceramic implants. Sammy Sandhouse was actually a huge pioneer. In 1965, he developed this and patented the CBS implant, again, alumina, and it was sold and commercialized throughout Europe in the 60s. And as we all look back at Professor Brannemark's work, first implant was placed in 1965 and only commercialized in the 80s. So we had ceramic implants in mouths for 15 years prior to titanium implants being commercialized. That's a huge achievement. So let's look at the material behavior. And as I've highlighted, we're looking at the flexural strength as well as the compressive strength of both materials. And you can see that the TZP or zirconia is about 2 to 3 times stronger in flexural strength and around 3 to 4 times stronger in compressive strength. So it's actually stronger than titanium. What we're challenged with is the shear forces, and that's something that we need to really take in consideration when we're choosing on the implant sizes and implant protected occlusion. Now, in terms of mechanical behavior, zirconia is brittle, but it's brittle just from a material science perspective, meaning zero plastic deformation, so little to no elastic limit. So this doesn't mean that it's brittle and it's going to break. It just means once you get past that point of elasticity, it's going to snap. And, in order to reach those thresholds, it's virtually impossible. So a colleague of mine who's involved in the manufacture of these implants says that zirconia is a very honest material. And so with titanium frameworks, you know, with overload, you're going to get not necessarily implant fracture, but you're going to get a lot of deformation over a long period of time. And we see that. So this is the number one reason or the number one concern or the number one barrier for dentists starting this zirconia implant journey. And this is a real concern that I shared early on. So let's look at the data. So if we look at this meta-analysis, which is the highest form of research, systematic review and meta-analysis, on the left we have a 0.65 fracture rate. This is looking at over 4,000 implants, and we compare that to 0.44% fracture rate among titanium implant. So it's very much statistically insignificant. So what we know now is most of the implants which fractured are no longer present. Again, inferior materials, inferior production, and manufacturing methods. And a lot of these most of these fractures happen in 3.25 millimeter implants, which are no longer in market. So there was a 15-year study, which I will talk about later, which had 1,800 implants used on 800 patients, and in 15 years, only one fractured implant. That's incredible statistics. In the last decade of placing implants, I've only had one failure in terms of a fracture failure, and it wasn't catastrophic. It was a patient who lived very far away. He called the clinic. He mentioned there was something that wasn't quite right, something was loose. We'd urged the patient to come in. He decided not to for weeks, and by the time he came in, the cracks had propagated. So this is not a concern, really. I think the data is overwhelming. So this is what you do when you have a little bit too much time. So when I was at Z Systems in Switzerland, I decided to grab a hammer. I wanted to see just how strong these implants were and put the implant on a bit of wood. And I smacked it multiple times and it didn't fracture. And I decided to record the video, post it. And a lot of the comments were that, oh, it's wood. Naturally, it's going to absorb the zirconia implant. And so I decided to do the 2.0 test on concrete. So let's have a look what happens. So a lot of patients have a belief that ceramic implants, also known as zirconia implants, are fragile, brittle, and are likely to break. I want to do an experiment to show you just how strong they are, the famous hammer test. Wow. So yes, it's not ISO standard or it's not a scientific experiment, but really the video is powerful. I like to show this to patients, I like to show this to other dentists. The implant just does not break. It's so strong. So let's talk about some of the benefits. Well, we know it's metal free, and some percentage of the population do have metal hypersensitivity, which we'll talk about later. It's white, and that's a huge benefit in anterior cases, really in any case where there's a risk of the implant or the gray showing. It's very biocompatible. It doesn't leach material. It integrates beautifully with the soft tissue. It's aesthetic, and a big factor is actually patient demand, which we'll explore later. So why does color matter in the aesthetic zone? Well, we know that the anterior maxilla is biologically and aesthetically very challenging due to thin facial bone, thin soft tissue. We have patients with high smile lines. And even with ideal implant placement, you do your GBR, your CT grafting, there is some long-term tissue remodeling which may occur, and there's a risk of scarring. The more surgery you subject the patient to, the more visible scarring you'll see, which is very unsightly. So why do we use zirconia? Well, as we discussed, thin biotype, they pose a huge risk. The gray hue through the mucosa, which you can see, it does require soft and hard tissue grafting. So where does zirconia come into place? Well, thin biotype cases with the transmucosal color show through. So it doesn't change your surgical protocol, but it means you have a lot more room for error. And if you have some facial bone loss over the time or some thinning of the mucosa or the soft tissue, you're not going to get this unsightly appearance. The risk of mucosal recession is not a huge issue. Patients really don't have an issue with seeing some white. High smile lines with gingival display, as we talked about earlier. What about the biological response to zirconia? So I spoke to a periodontist who was running a full arch clinic in America. And during our conversation, it turned out that he stopped doing titanium implants and converted his whole full arch practice to zirconia. And I was gobsmacked. Why on earth would you do that? And I posed the question to him, and he said, simple, Sam, for one reason, because of significant reduction in peri-implantitis. And being a periodontal practice, that's naturally what he's going to see. So that was his answer. That was his rationale for converting completely to a metal-free practice. So let's look at the data. Well, we know that zirconia is very biocompatible. It does not release metal ions, and it's very stable in the oral environment. We have a relatively low plaque affinity, so plaque does not like zirconia, and we know that. All the data is showing that when you get back your implant crowns, you shouldn't leave the glaze on, you should polish it back so you get some really nice hemidesmosomal attachment. Favorable soft tissue integration. I see that when I place my zirconia implant, patient comes back a week or two later, It's like a ninja's gone in there, done the surgery, and covered it up. You almost don't see any trauma to the site. So this is a study, really big study, that shows, again, a significant reduction in biofilm on polished zirconia. And we know biofilm is a huge risk factor or one of the main causes for peri-implantitis. So what about the ion release? So sometimes we have these cluster failures which we can't explain. We put these implants in, we've done the surgery really well, we followed surgical guidelines, we get the torque, we cover it up, the surgery was not eventful, and you get a cluster failure. The implant comes out. You decide, you have that discussion with Mr. Jones, and Mr. Jones, we're going to take the implant out, we're going to put a bigger one in or one that's deeper so we don't have to wait for healing time. We can put it in straight away. You do it again and it fails again. So, and I've seen plenty of case reports for full arch cases where this has happened, and you've all had it in your practice, and you put it in the I can't explain or the randomness basket. And yet, in these few cases which it's happened, we replace that metal implant with a ceramic implant, and suddenly it works. This has happened to me. Can I explain it? No. Do I have a gut suspicion? I think I do. So zirconia does not release any ions. It's completely chemically inert, corrosion resistant, whereas titanium releases ions through corrosion, through movement, through friction. And these ions, it's been shown, can promote inflammation in the area in susceptible patients. Who are those susceptible patients? Well, we're going to find out. Here's the study. Again, a systematic review. Titanium particles and ions have been shown to trigger local inflammation, osteolysis, and peri-implant tissues. So when you remove, if you've ever removed titanium implants, you've had to either torque it, reverse torque it out because of a failure, or trephined. It's very common to see gray, and those are the titanium particles, whether it be through corrosion or when you've initially put the implant in with high insertion value, we know that this material leaches. So how do we test for this? Well, this is called the Melissa test. And why it fails? Well, firstly, when we do the scratch test, we're looking at titanium particles, the titanium dioxide, which is actually a white ceramic found in as a white pigment in sunscreen. And if you have a look, the Mayo Clinic America, in a whole decade of patch testing, found zero positive reactions. So why does this happen? Well, it's the wrong ingredient. We're actually looking for free titanium ions. They're the ones that cause the type 4 delayed sensitivity. So the Melissa test, unfortunately, is not readily available. It's available in about 2 or 3 countries in Europe and in Israel. It's the only validated method to confirm or exclude titanium hypersensitivity. And 4 to 6% of patients test positive, the ones who are symptomatic, meaning i.e. pain, redness, swelling, are going to be significantly higher. 4 to 6% is not insignificant. That doesn't mean that every one of these single patients is going to have an implant failure, but I sure as don't want to put these implants in patients who have a confirmed hypersensitivity. So something to be mindful of. What about the soft tissue integration? Well, zirconia supports excellent biocompatibility. And again, as we talked about, removing the glaze off the crowns promotes a tighter adaptation, faster epithelial cell attachment. Again, healing is so much faster, as I mentioned earlier. We get a much denser and tighter collagen and connective tissue around zirconia. And this is really important. Zirconia abutments demonstrate lower inflammatory responses and reduced biofilm compared to titanium, potentially reducing pocket depth and inflammation. Again, inflammation is a huge driver which progresses to peri-implant mucositis or peri-implantitis and finally implant loss. This is a systematic review. So Professor Alessandro Pozzi, who's a prolific researcher and clinician in FP1 cases, doesn't recommend cleaning underneath zirconia prosthesis because of the attachment to the zirconia, the polished zirconia. This is a huge paradigm shift. And you've all seen it when you remove that really well polished zirconia from the, I guess, the peri-implant tissues, if you've had to remove it to adjust contacts or something after it's been there for some time, you break the seal and you can see some bleeding. You don't tend to get that around glazed surfaces. What about the osseointegration of zirconia? This is a concern as well. Let's look at the data. Again, a systematic review and meta-analysis. So zirconia and implant demonstrate a similar soft and hard tissue integration capacity. This is the important point. However, titanium tended to show a faster initial osseointegration compared to zirconia. So what does that mean? Well, it means you don't need to use an SLA active surface and load the zirconia implant in 4 to 6 weeks. Just going back to original good surgical protocols. So waiting 3 months in the mandible. I sometimes wait 4 months in the maxilla. That's more than enough. And test it. You've got the IST, ISQ testing. So not a huge problem. And if you're getting 35 Newton centimeters and you're immediately loading or temporizing the implant, no problems whatsoever. So let's look at the long-term data because this is the rationale of why and how we should be treating patients, not because of a case study or because a company told you, but because of good data, not a case report, but systematic randomized control trials. So just keep in mind that we're looking for 10-year data, which is really the gold standard. And out of more than 3,000 implant companies around the world, I looked at this into this, only about 10 have longer than 10-year data. And these are the implants that are placed around the world. And that's quite scary if you consider what it means. So here's the first study, 15 years survival rate, 15 years. Over 1,800 implants were placed in about 800 patients, 98.7% survival rate. That's huge. That's incredible. One fracture, they were placing these implants immediately in smokers, all different sizes. Second study, first study is on a one-piece implant, second study is on a two-piece implant. 10-year survival, really high, 97.7% success rate. Third is a systematic review. They looked at 4,000 implants, a cumulative survival rate of 95%. This data is convincing. This data allows you to integrate zirconia implants into your practice, knowing that you're going to have as high a success rate as titanium implant, or at least comparable. What about immediate loading, bridges, full arches, full dentures? Let's look at the data again. So on the left, we have a systematic review looking at immediate implants over about 5 years, 95.1% survival rate. Again, very high. So implants that are placed immediately, no problems whatsoever. 3-unit bridges, again, quite high. One concern is overdentures. 12-month data, quite low success rates and survival rates. I don't know why, but unfortunately the data is just not there. So consider not doing it. And here's another 3-unit bridge. Again, pretty high survival rates. So what does all this mean? Well, it does support single units and you can be quite comfortable doing it in your practice, 3-unit bridges and immediate cases. However, it does not support across all bridges. I would not be jumping at full arch cases, overdentures, or long span bridges. Refer to somebody who's got experience or is very comfortable. You don't want these headaches because if this fails, it's an absolute disaster. And also claiming it's superior to titanium. We're talking about where it can be used, not when it should be replaced or when titanium is no longer a great material. Okay. So where do they fit in practice? So aesthetic zone, all my anterior cases are zirconia implants, not because of me pushing this upon patients, but I have that discussion with patients. I show them the pros and cons, show them both implants, and patients almost certainly always pick zirconia. So as we talked about, patients who have a metal allergy, a known metal allergy, I would recommend sticking to ceramic if you have issues down the track. You're going to have to replace that implant. I have a nickel allergy. I can't wear stainless steel watches. So if I needed an implant, I would go for ceramic 100% of the time. Patient preference, we'll talk about this later. But this is really talking about that informed consent. It's about showing the patient all the options. This is viable. The long-term data is there. So why aren't you showing this to your patient? And finally, thin gingival biotype cases. If this goes pear-shaped, at least you've got another layer of protection with ceramic implants. So this was a really interesting questionnaire administered to 300 patients in Germany and Switzerland. And let's look at some of the questions and the answers. 80% of patients would prefer zirconia implants when given the choice. That's a significant proportion. And mind you, this study or this questionnaire was given out in 2011, 2012. And the main key motivating factors were aesthetics, the look, the color, the perceived strength. Interestingly, patients actually thought that ceramic is stronger than metal and reduced allergenicity. So additional treatment cost is not viewed as a deterrent. So what that means is most patients were happy to pay additional for a ceramic implant. So just to give you a bit of background, titanium implants cost around 10 or 15 euros to manufacture, whereas ceramic implants are almost 15 times that. And we're not being charged 15 times more from ceramic implant companies. So that's something to consider. Patients have no concern paying for extra. Patients are increasingly informed. As we talked about earlier, then they are actively requested, not just something that's accepted. So I've had so many patients that have had titanium implants placed years ago. They've come into my practice or been referred for a ceramic implant or even just to explore implants. I've shown them both options and they make that remark, "Oh, I'd wish I'd been offered a ceramic implant earlier. I would have chosen it." So patient preference is a legitimate clinical consideration. You need to have those discussions with them. So let's talk about what type of patients you're going to be seeing, what type of patients you're going to be attracting, and maybe the different marketing strategies. So your first patient, I call it the immune compromised metal sensitive patient. They are driven mainly from health concerns. They've got autoimmune conditions or other health concerns and battles. They've been on a long journey. They don't want to aggravate anything. They may have some metal hypersensitivities, and for them, they will not choose titanium. It doesn't matter whether they go to the best implant surgeon, their drive, their motivation is to avoid metal at all costs. And they're going to be grateful patients because the expectations are not overly high. They just want a non-metal implant. And these patients will find you online, word of mouth, naturopaths, holistic practitioners. Your second type of patient is the health conscious lifestyle patient. So these are generalizations, not exactly how these patients presents, but just some general guidelines. So these type of patients are your 30 to 40-year-olds. They're very much focused on wellness. They're focused on the aesthetics. They have very high expectations and they're also quite demanding, but they're grateful. And these type of patients will post your cases, will share you, will, you know, talk about you on different forums, yoga studios, Pilates, wellness. It's a good idea to go to those centers and advertise if you can in your region. And finally, your third patient is one that who just doesn't know. They're coming in for your opinion, for your clinical recommendation. They don't know about titanium. They don't know about ceramic. And these type of patients, depending on how they're wired, depending on their philosophy, as an example, male engineers will generally always go for titanium because that's just how their mind operates, whereas some patients will go for ceramic. So your marketing strategy is going to be very different for all three type of patients. So let's go through the ideal starting cases. These are your posterior teeth. I would say, molar, premolars, delayed, so something that's already healed. It's had 3, 4 months of healing or longer. I would stick with the two-piece implant, easy to submerge. You don't have to worry about, if you don't achieve the primary stability, especially if you're starting on these cases, you might find the drill protocol is a little bit different to what you're used to. Good bone, that's what we want to see. So what about your yellow cases? These are for clinicians that are quite already experienced or have had 5 to 10 cases under their belt. So anterior tooth aesthetics, they're always generally quite demanding. One-piece implants, the reason I say that is one-piece implants need to be very strategically placed, they need to be prosthetically driven. If you put in the wrong position, depth, angulation, yes, while you can adjust it, it's going to be a nuisance, and sometimes it's just not going to be an optimal result. So cases with grafting, immediate placement cases, as I said, after your first few cases, I would then go and tackle these ones. And really, the red ones, these are the cases that you really want to refer. Significant vertical cantilevers, full arch cases, and severe bone deficiency. Send them to dentists, in your area that you don't like or who you're in competition with. So the reason I put this is not a plug for Z Systems, but rather, one of the big frustrations that clinicians who place a lot of ceramic implants have had in the past, and I've, spoken to clinicians at conferences, is a lot of implant companies have been around for a few years, they're looking great, they're doing manufacture, and then suddenly the next day they close. You can't get parts. During COVID, a prime example, as I placed a lot of ceramic implants, especially in anterior areas, and the company said, sorry, we're no longer manufacturing or we can't access parts. And so I've got all these irate patients who are waiting for the teeth. So what do I do? A lot of ceramic implant companies come and go, and this is a huge frustration. So, as you can see, Z Systems has been around for over 20 years. They're not going. They're here to stay. They don't have issues with parts. They have a clinical support team. They have clinicians on board. So if you're going to start in a journey, start on a company that will support you, from day one till to the day you retire. So Z Systems range, there are three implants, very innovative. The tissue level, depending if you like tissue level implants, the one-piece implants, which I generally prefer in the molar sites, and then the two-piece bone level, which for me, I apply clinically in premolar to premolar areas. So this is something very unique, the Morse taper. So this acts as a one-piece implant. It's quite incredible. You put the abutment inside the implant and without the screw, and it's almost locked in. The manufacturing precision and the tolerances to manufacture this, I haven't seen any other company even come close. The screws are 100% ceramic. Again, something innovative, something that's been around for a long time with Z Systems. A lot of the patients who want a ceramic implant are not happy about not having a ceramic screw. So if you're using other systems which have a metal screw, titanium screw, you should tell your patients, and you'll be quite surprised on how many of them will refuse the treatment. So very impressive. So let's talk about some of the surgical principles that are a little bit different for zirconia implants. Firstly, prosthetically driven planning for one-piece implants. Use a surgical guide for your first 5 to 10 cases. As I mentioned, the room for error is very minimal. It's very small with these one-piece implants. Excessive torque during placement increases the risk of implant fracture. As we talked about, one of the only downsides of zirconia implants is shear forces. There's just no need to go to 80, 90, 100 Newton centimeters. We're not placing pterygoid implants or extra long implants. If you want to put a tooth on there, aim for 35, 45, 50. I don't see any benefit in going that far further. And a lot of these ceramic implants will have breakers or transfer pieces which have a safety mechanism built in. The one piece doesn't. So just be mindful of your torque and reduce speed when you're placing it. Zirconia is a poor thermal conductor. So if you're spinning in the implant at 50 or 100 RPM, that heat doesn't have anywhere to go to, doesn't dissipate. Like in a titanium implant, which is a great electrical and thermal conductor, it will go to the titanium implant, whereas here it'll stay in the bone. So just go slow. 15 Newton center, 15 RPM. I like to finish them off by hand, so I'm in the right position, depth, angulation. So these are just some loading protocols. So immediately, again, good sound surgical principles. These are for the one-piece implant. If you achieve over 35 Newton centimeters, you can put your provisional tooth or an Essex retainer, depending on which way you'd prefer to go. Less than 35 Essex retainer. With these Essex retainers, it's really important that patients wear them throughout the whole night, especially with the tongue being a strong muscle. I like to tell them to wear it during the day, especially when they're eating, and for a minimum of 6 weeks. So if you're doing delayed cases, again, if you're achieving 20 Newton centimeters, put the Essex retainer on. If it's less than 20 Newton centimeters, take the one piece implant out. It's really important to talk to patients about the fact that if they've asked for a one piece implant, you need to have a contingency plan if you can't get the stability. So instead of aborting procedure, you've opened the surgical field, have a two-piece implant as a backup. And if you don't get the stability, take the one piece out, put the two-piece implant in, submerge it. You're done. For the two-piece implant, again, very similar. 35 Newton centimeters is that magical number. You can either put your provisional tooth or, again, just put a healing abutment on. If you're getting 20 Newton centimeters in a delayed case, again, healing abutment. And if you're under 20, just submerge the implant. It will heal. So prosthetic protocol, I've divided into one piece and two-piece implants. So one piece implants, again, because of that incredible attachment on zirconia, often you'll see that majority of your one piece implant cases, the soft tissue will grow on top of the implant shoulder. So you'll need to use laser or a scalpel. Don't use diathermy or anything else that's going to generate too much heat, like cauterizing it. So you scan the abutment and it's very easy. You can design it and print it, mill it in-house or send it to a lab. With a two-piece implant, if you're doing a bone level, you put a scan body and it's a direct to fixture, whereas at tissue level, you need to screw down the abutment and then cement the crown on top of the abutment and implant. So just to go through a few cases, we have the first case, which was a 52-year-old female. The tooth 22, as you can see, was extracted at another practice. It's a very difficult case. There was a cyst. There was significant horizontal and vertical bone loss. So she presented to the clinic, and naturally, these cases always come with high smile lines, thin biotypes. So we attempted vertical grafting, soft tissue augmentation. Patient was very motivated for metal-free solution, didn't want another implant system with a metal screw. So we put the 3.6 by 10 millimeter implant. The case took about 18 months in total. So, and there's the result. Patient was very, very happy overall compared to, where she came from to the final result. And just a couple of posterior cases. The one on the left is a two-piece implant. The one on the right is a one-piece implant. There's the result. Look at the soft tissue, just how beautiful it looks, how glistening. And with this particular case, you can see that I don't have enough space for my implant crown. So these implants are safe to grind, and I ground the distal portion about a millimeter down. So you have enough thickness for your zirconia crown and cemented it with a resin-based cement. There's a result of the two-piece. You can see that soft tissue when I took the implant crown off. There's a ceramic screw, and there's the final result. So let's summarize this. Zirconia is a high-strength ceramic. Please don't worry about fracture. It doesn't happen. Don't let that be the reason you don't attempt this. Don't let this be the reason that you don't offer this amazing solution to your patients. So we get some amazing aesthetic and tissue properties, which we don't have with titanium. We need to do more grafting. It's not a complete replacement for titanium, as we discussed. Full arch cases is a no-go. Overdentures, stick to the green cases. Case selection is critical, as we talked about earlier. Surgical and prosthetic discipline matter. Follow those biological, sound, surgical, and prosthetic protocols. And these systems can be integrated thoughtfully to your practice with confidence. So I just want to leave you all with a closing thought. Zirconia implants are not about replacing everything we know. They're about expanding our treatment options for the right patient, the right site, and the right protocol. The clinicians who use zirconia most successfully are not those who favor them unconditionally. They are those who understand where they fit, where they do not, and how to execute the workflow and discipline with precision. Thank you. And if you have any questions, please don't hesitate to reach out to Z Systems, or please DM me or send me messages or to discuss cases on my Instagram. I can guarantee you that once you start with ceramic and you see the incredible benefits, you won't stop and your practice will slowly change. This is the material, not necessarily of the future, this is a material of the now. Thank you.